Hey, good evening, everyone. I hope you are fine. I hope you all had a good summer vacation and that you are now fresh. And welcome to a new EUROPREV webinar. Today we have two very interesting topics. We are going to talk about benefits and harms of the new hypertension guidelines, and we also are going to talk about benefit arms about AAA screening. Help me, aortic abdominal aneurysm screening. Is it correct? Okay. Okay. We have two great speakers for tonight. I will start now presenting them, and I will also presenting Rosalia, that you already know from the previous webinar. Rosalia is coordinating assistant from EUROPREV, and she's here to help me during this moderation. Hi Rosalia, how are you?
Hello, good evening. Good evening everyone, or good morning or good afternoon as appropriate. So as Carlos said, my name is Rosalia Páscoa. I'm a GP in Portugal, and I'm here to give a little help in this webinar, in this very, very interesting topic. So thank you.
Okay. And now from Sydney, we have Katie Bell with us. Katie, good morning to you. You are already on the next day.
That's right.
Katie is a researcher from the School of Public Health from the University of Sydney, Australia. So thank you very, very much for being here, because in Sydney it's 5 a.m. So it's really, really early. And thank you so much for the sacrifice you are doing. Katie, welcome to our webinar. So,
thank you very much.
Okay. Have I presented you well, or would you like to add something else about your professional activity?
Sure. So I'm a clinical epidemiologist, and I, as Carlos mentioned, I work at the University of Sydney here in Australia, and I teach and research about medical tests. So these are tests used for screening, diagnosis, and monitoring.
Okay, thank you very much. And now, dear colleagues, I will present another speaker. With us, we have Mina Johansson. Mina Johansson is also a researcher from Sweden. She works at the Cochrane, Sweden, and she's also a general practitioner. Mina, good evening. How are you?
I'm fine, thank you. Very fine.
Okay.
Very nice to be here.
Very welcome, and thank you for being here with us in this webinar. Would you also like to add something else about your professional activity?
No, I think it's fine. I can get back to that during my presentation.
Okay. Very, very well then. So, I will now share with you, Mina, Rosalia, and Katie, some methods that we are already receiving in our web chat. For example, we have a message from Anna. Good evening. The children are finally sleeping. I'm ready for an interesting webinar. Hi, Anna. Thank you. We have another message from Marina. She says, greetings from Bosnia. I hope you all had nice summer vacations. Hi, Marina. We had. It were really great and wonderful. Message from Feyzanur. Good evening from Turkey. Hi to Turkey. And so many messages also from Italy. Rosario Falanga. Hi, everyone from Italy. Hi, Rosario. How are you? So we have colleagues from all over the world, I would say, or from many countries. And I think that we now can begin, Katie, with your presentation. And your first slide, to begin your presentation, is already a televoting questions. So I will activate here to see if we have already some results. And dear colleagues, during this webinar, we will have some questions so that you may also participate in our webinar. So I would like to invite you to open the link that I have shared in the web chat so that you can, and let it open in another browser or in another tab of your browser so that you can answer each time I activate a new question. And the first question was about the hypertension guidelines. Please tick the correct statement. First option said the 2017 ACC and AHA lowered the diagnostic threshold for defining hypertension to 140/90 millimeters mercury. The second option said 2018 European Society of Cardiology and European Society of Hypertension guideline and the 2019 NICE guidelines lowered the threshold for defining hypertension to 130/80 millimeters mercury. And the last option stated that 2017 ACC-AHA threshold is 130/80, and the 2018 European guidelines and 2019 NICE guideline threshold is 140/90. And Katie, about 60% of our colleagues answered the third option. The third option is that one that American guidelines is 130/80 and the European guidelines 140/90.
Yep, and that's the
correct
answer.
Okay, you may now start your presentation, please.
So if we move to slide number 3.
Yes.
Yes.
Yeah.
This talk is on the benefits and harms of the new guidelines, but with a focus on the American guidelines in particular. So the 2017 American College of Cardiology and American Heart Association lowered the diagnostic threshold for defining hypertension from 140/90 millimeters of mercury to 130/80 millimeters of mercury. In contrast, the 2018 European Society of Cardiology and European Society of Hypertension guideline, as well as the very recent 2019 National Institute for Health and Care Excellence guideline, did not lower the threshold. And so I'll focus on the American guideline, but compare and contrast this with both the European and the new UK guideline. So the next slide is another polling question, I think, Carlos?
Yes, okay. I will activate the new questions and we will have to wait. And dear colleagues, we would like to know, what do you think? What do you believe? Do you believe that hypertension is a disease in itself, or hypertension is a risk factor, not a disease in itself? What is your opinion? I think we have to wait a little bit. Is this important, Katie?
What's that?
To believe that hypertension is a disease in itself or not, or to believe it is a risk factor, is it important in your perspective?
Yes, so I think that it is, in that if you're thinking about things that matter to patients, it's clinical symptomatic disease that is troubling them and causing problems to their life, rather than a risk factor is usually not clinically symptomatic, and it increases your risk of developing the clinical disease. But a risk factor in itself, I wouldn't think is a disease if it's not causing the patient
Mina,
problems.
what is your perspective about this topic? Is it important that we acknowledge the right disease as a disease, or sometimes we tend to call disease what is only a risk factor?
Yes, I do think it's important. I think it's quite funny. We tend to, when patients come and they say, and we ask them if they're healthy or sick, and they say that they're healthy, but we see them as sick because they have so many pills, and we sort of make fun of that. I think it's actually quite good, because actually they are healthy. They just have risk factors, and I think this is very important. And we should have more studies on how patients perceive these labels. That's usually important to me.
Okay. I think you both will be surprised with the answer that we have here, but 60% of our colleagues believe hypertension is a disease in itself.
Okay, so it is a little bit blurred, I guess, in that I guess severe hypertension can sometimes cause symptoms, and so in that respect, it could be thought of as a disease. But I think usually I would think of it as a risk factor rather than a clinical disease. So can we move to slide 5, please?
Yes. Okay, yes.
So the 2017 American guideline follows a general pattern across medical specialties whereby disease definitions are more frequently widened than narrowed. And I would argue that hypertension is in fact not usually a clinical disease in itself, and that people with elevated blood pressure do not generally have symptoms, and that rather it's a risk factor for cardiovascular disease, which is the true disease that causes symptoms and morbidity. So there's no discrete boundary that defines the hypertensive state from the non-hypertensive one, and judgment is required to determine where the diagnostic threshold should sit on this continuous spectrum. So in contrast to standards for producing trustworthy and transparent clinical practice guidelines more generally, until the last couple of years, there were no published guidance for modifying disease definitions, which is surprising but true. Can we move to slide 6, please, Carlos?
Yes, it's done.
So to address this gap, members of the Guidelines International Network Preventing Overdiagnosis Working Group, led by Jenny Dalst and Paul Glaggio here in Australia, developed an 8-item checklist to encourage guideline makers to explicitly consider both the benefits and harms of changing a disease definition. So we decided to apply this checklist to the new American blood pressure guidelines in order to assess the extent of benefit and harm of the change in definition. And slide number 7, please.
Yes, it's done.
So the American College of Cardiology guideline was released as an update to the 7th report of the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure, or the JNC7, which was actually published way back in 2003. After that time, there was a JNC8 and also an American College of Physician guideline released and more recent than the JNC7. However, those two American guidelines didn't provide explicit diagnostic thresholds or definitions of hypertension, and instead focused on the treatment thresholds. So in order to estimate the incremental benefits and harms, that means the sort of additional benefits and harms compared to the previous definition, we compared the 2017 ACC guideline to JNC7 from 2003. And in the table that you should be able to see on the slide, I've also included the 2018 European guideline and the 2019 NICE guideline for comparison. And just from looking across the table, you can see that the new American guideline really stands out from all the other international guidelines as having the lowest diagnostic threshold for hypertension. Excuse me. So the new American guideline recommendation is for diagnosis of hypertension rather than pre-hypertension for adults with a systolic blood pressure somewhere between 130 and 140 millimeters of mercury, or with diastolic blood pressure between 80 and 90 millimeters of mercury. And the recommendation is for immediate drug treatment for high-risk people within this blood pressure range who have existing cardiovascular disease or a calculated 10-year cardiovascular risk of 10% or greater, or some other high-risk characteristic, for example, diabetes or renal disease. And so slide number 8, please.
Okay.
Okay, before you go on, I have here a comment from a colleague. He or she says, we are just arguing about this topic of being a disease or being a risk factor.
Okay, yeah.
He says, we are just arguing semantics. It depends on our definition of the terms. Where is your line drawn? Plus, the two terms aren't mutually exclusive. Smoke addiction, for instance, is both a disease, if you consider it a mental health issue with dire consequences, and it's at the same time a risk factor. Do you want to comment on that?
Sure. It's an interesting discussion. So he was talking about smoking, is that right?
Yes, he
Was the example?
he
Yeah.
gave the
So I
example
think
of
that-
smoking
Sure.
addiction.
Smoking addiction. So I think that he's right, that smoking addiction and any kind of addiction does impact on the person's life, and particularly if they're wanting to give it up and they can't, and that I would call it a disease in that respect. But it is also a risk factor for, like a very important risk factor for cardiovascular disease and cancers. However, a lot of risk factors, and I would include hypertension in this category, are not apparent to the person until they go to a doctor who makes a measurement of some test on them and then tells them that, no, you have this abnormality and you have this disease, and then gives them a disease label, which is what Mina was picking up on before, and tells them, no, well, you might feel like you're healthy, but actually you're sick. You have a condition. So in a way, it's sort of making the healthy sick by
Yes.
by them coming to the doctor and the doctor telling them that they are the patient and that they're sick.
Okay. He wrote, he or she, I don't know, because he identifies himself as PR. PR also wrote then, following this reasoning, the term coined by family medicine, problem, seems like a more practical and nonchalant approach. It's between. Cheers from Portugal, says PR. I would also like to comment this topic. I agree that sometimes there is not a limit or a distinction between some entities, and there are some situations that they may be labeled as diseases, and also at the same time be risk factors for other problems.
Sure.
However, I believe that in this case, when we talk about hypertension, when we talk about cholesterol, for example, and
Or
even
osteoporosis to find on bone mineral density testing.
Yes.
Yeah.
I think there has been, I would say, an excessive labeling of health problems as diseases. And this is a traditional disease-mongering strategy. And there is also an additional problem when we label someone that is healthy and he has only a risk factor, and you label him as a sick person. And this is a problem because this person will be affected by this labeling, by this diagnosis. And we also know that usually there are powerful forces behind this tendency to over-label healthy people with diseases, because usually a disease gets also a sort of treatment. Or,
that's right.
Or is also accompanied with excessive medical tests, imaging tests, lab tests, and so on. So there are many factors that contribute to an excessive medicalizing of our daily life, and this is a problem in these days that we live. So
yeah, I agree.
Mina, do you want
and
to?
I guess
Mina, do you want to add something?
Me? No, I just said that I agree too.
Okay. Katie, you may go on with your presentation. I'm sorry that I interrupted you.
No, I that was a very interesting discussion, and I'll touch on the whole labeling issues and overdiagnosis as we go on in my talk. So I think we're up to slide 8. Is that right?
Yes.
Yes.
So this is we're now up to the second item of Jenny and Paul's checklist. How will the new disease definition change the incidence and prevalence of the disease? So a large proportion of the world's population would be classified with and treated for hypertension under the new American guidelines. For example, approximately 103 million adults in the US would be diagnosed with hypertension, or 46% of the total adult population. This is 31 million more people than under JNC7. Approximately 82 million would be recommended for immediate drug treatment, or 36% of the total adult population. An analysis by Kira and colleagues in BMJ last year focused on US adults aged 45 to 75 and found that 70 million in this age group would be labelled with hypertension, representing 63% of the population within this age group. That analysis estimated that 15 million people would be immediately recommended to start treatment and 25 million people recommended to intensify their treatment. They also looked at China, and they found that if China was to adopt the guidelines, 267 million adults aged 45 to 75 years would be labelled, representing 55% of this age group. An estimated 130 million people would be recommended to immediately start treatment and 66 million people to intensify their treatment. And similar estimates to these of the proportion of the adult population who would be diagnosed under the American guidelines with hypertension have been found in Europe, Australia, India, Bangladesh, and Nepal, and probably more countries than that. That was a while ago that I had looked for where the prevalence estimates had been done. So a large number of additional people would be diagnosed and treated for hypertension if the American guideline were to be applied globally. Can we move on to slide 9, please?
Yes, already.
So this one is quite an interesting one. This is checklist item 3. What is the trigger for considering the modification of the disease definition? So the stated motivation by the ACC guideline was to ensure that the guideline recommendations remain current, even though actually there'd been some other guidelines that had come out not that long before the 2017 one. It seems, however, that there's a particular emphasis on the finding of benefit with lower blood pressure target in the SPRINT trial. The evidence review for the treatment target question, which formed the basis for modifying the definition of hypertension, focuses on trials comparing lower and higher target blood pressures. And it appears that HOPE-3 and other trials of active compared to placebo drugs were not included in the evidence review. Similarly, other RCTs and systematic reviews that didn't explicitly compare a higher versus lower target appeared not to have been included, despite being included in the evidence for the JNC8, the American College of Physicians and the American Academy of Family Practice guideline, the 2018 European guideline, and the NICE guidelines. So it seems the American guidelines didn't include some key evidence that the other guidelines did. Interestingly, 3 of the writing committee members, including the chair of the American Guidelines writing group, had leadership roles in the SPRINT trial, and no committee members had such roles in the HOPE-3 trial or some of these other studies. So interesting that could have been one of the triggers for deciding to modify the disease definition.
We may also add that the American Academy of Family Physicians did not endorse these guidelines, these new guidelines.
That's right. So they were quite strong coming out of the press conference that they did not endorse them, and the American College of Physicians also had said that they don't endorse them, amongst others.
Okay.
Yeah. So it's been controversial both within the US and internationally.
Okay.
So slide number 10, I think.
Yes.
Yes. So we're up to checklist item 4, which is how well does the new definition of disease predict clinically important outcomes compared with the previous definition? So in terms of absolute risk, the relationship between systolic blood pressure and cardiovascular mortality and cardiovascular events is what's termed as log linear. So there's progressively greater increases in absolute risk of dying from cardiovascular disease, the higher an individual's systolic blood pressure within each age group. Individuals with a systolic blood pressure of 130 to 140, which would be the people who would be newly diagnosed as having hypertension under the American guideline, have a lower absolute risk of cardiovascular death compared to individuals who have a systolic blood pressure greater than 140 millimeters of mercury. So this means that overall, the newly diagnosed individuals have a lower absolute risk of cardiovascular death, and the new definition, therefore, means that people have a lower risk of cardiovascular death compared to people who are labelled as hypertension under the previous definition and also under the European or NICE guideline definitions. Move on to slide number 11.
Yes, okay.
Yes, okay. So the 5th checklist item is what is the repeatability, reproducibility, and accuracy of the new disease definition? And I'll go into this a bit more later in the talk, but just briefly, systolic blood pressure has poor reproducibility. It's known for large amounts of measurement variability. There's a 10 millimeter mercury standard deviation, just random noise is what we call it. If you do repeated measurements at different clinics, closely spaced in time, like maybe over like a few days. The emphasis in the American guidelines on averaging out-of-office blood pressure measurements reduces, but does not eliminate this replication issue. And in fact, because a large proportion of all adults in the population have a true systolic blood pressure, which is quite near to the 130 millimeter threshold, this inherent variability in blood pressure will increase the potential of getting diagnosed with hypertension. And as I mentioned, I'll come back to this checklist item in a little bit, and we'll look at the implications of this in more detail. So if we can move on to slide number 12.
Okay, it's done.
So checklist item 6, what is the incremental benefit for patients classified by the new definition compared with the previous definition? So on the slide, there's a nice graphic from Johan Sundstrom's Lancet paper, and I'll explain a little bit about what this shows. So the incremental benefits of blood pressure lowering depend on the baseline risk of cardiovascular disease. And this is the baseline absolute risk of cardiovascular disease. And the blood pressure lowering treatment trialist collaboration, which this figure is from their paper, allows us to group the information from blood pressure trials together in an individual patient data meta-analysis to understand the relationship between the baseline predicted risk of a cardiovascular event and the clinical effectiveness of blood pressure lowering treatment. Their analysis showed that the relative reduction in events achieved by blood pressure lowering treatment is similar for each quartile of baseline absolute risk. So because the relative risk is similar, this means that the absolute risk is actually greater for people who are at higher baseline risk. And so they have more to gain from treatment in absolute terms. So the figure shows that the estimated number of events avoided with treatment is greater the higher the person's baseline risk of having the event. Other key trials that we might use to estimate the benefit are the SPRINT and HOPE-3 trials that I mentioned earlier. So participants in the SPRINT trial had a calculated baseline risk that's similar to the second quartile of the meta-analysis on this graph. And so they had a greater than 20% 10-year risk. And according to SPRINT, 16 cardiovascular events would be avoided per 1,000 people treated with 15 millimeter mercury systolic blood pressure lowering over 3.3 years. In contrast, participants in the HOPE-3 trial had a calculated baseline cardiovascular risk that was lower than the first quartile of the meta-analysis shown here. So these people aren't even represented on this graph because their risk was lower than any of the other trials. And so that they had approximately a 10% 10-year risk. According to HOPE-3, there were no cardiovascular events avoided per 1,000 people treated with 6 millimeter mercury systolic blood pressure lowering over 5.6 years. So they didn't find a benefit for blood pressure lowering treatment in that trial. And can we move on to slide 13?
Yes.
So we're still talking about the incremental benefits for the newly diagnosed. So people with a systolic blood pressure between 130 and 140 millimeters of mercury. So this table is based on the reported data from the US population impact study, which was published at the same time as the American guidelines. And it used the NHANES data to say the proportion within the US adult population that had different categories of cardiovascular risk. So most people have low risk, and it shows that 80% of the people who would be newly diagnosed under the American guideline have a baseline 10-year risk less than 10%. And based on the data I've just shown you, we'd expect that there's no benefits for these people in terms of cardiovascular risk reduction with blood pressure lowering. There's a further 11% who have a 10-year risk between 10 and 20%, and these people may expect a modest benefit. The remaining 9% who have a high baseline risk, greater than or equal to 20%, may expect a larger benefit in terms of absolute cardiovascular risk reduction. So that's a summary of the expected incremental benefits for the new guideline.
Let me see if I am understanding well.
Yep.
From this slide, from this table, we may see that most of the people that would get a new diagnosis with these new guidelines would have a very minimal benefit, absolute benefit. Is that true?
Because, so I think most of them would have
because most of them belong to a lower
benefit.
risk. Because most of them
that's right.
Yes. Okay.
So if we go through the rows, so 63% of the adult population actually have less than 5% risk, so very low risk, and then 17% of 5 to 10% risk, which is still low. And so all of these people would be labelled as having hypertension. According to the guidelines, well, the strict guidance in the guidelines, they shouldn't be immediately treated with drugs. They should be offered lifestyle counselling and try to improve their diet and exercise. However, it does seem to leave the window open that if that doesn't result in their blood pressure being lowered below the threshold, that then they might be offered drugs. So although in the column for newly treated, I've said that none of the people with a less than 5% risk would be newly treated. So this is based on what the impact study said should happen. I think in actual fact, quite a number of those people would be treated as well. So it's probably less favourable than this table shows.
Okay. In line what you were saying, we have some colleagues here writing in the chat calling for vegan diet and lifestyle modification that would be more helpful than changing these thresholds of the new hypertension guidelines.
Yes, no, I agree. Like, I think that I don't see why you need to change the definition of the hypertension like the threshold to be able to help people with a healthy lifestyle.
Okay. We also have here a question from Krista Ringers. What do we do with the 24 hours blood pressure definitions if the guidelines go as low as 130/80?
So the guidance for the out-of-office blood pressure measurements are that it's still the same 130 millimeters for systolic millimeters mercury for the threshold. So it's the same threshold used for office and for out-of-office measurements.
Okay. I think we can also make a comment because we note that the SPRINT trial had a great influence in these new American guidelines. And one of the problems of the SPRINT trial is the way the blood pressure was measured during that trial, because it was not the usual way we measure blood pressure in our clinical practice in our office. The patients would have to rest in a room with an automated blood pressure measurer. They would stay there for some minutes, and then without the presence of a health professional in the room, the device would measure the blood pressure. So the values of blood pressure that they got in the SPRINT trial probably in real world conditions would be the same values that we have, but they were exaggerated to a low trend because the setup that was used was quite different from the real world
That's
one.
true.
So the setup from the sprint trial probably is more similar to the values that we already use in the 24 and out of office measurements that we already use lower thresholds.
Yeah.
So that this was just
Yeah,
a
and
comment.
so for the 140 millimeter mercury threshold, it is recommended for the European guidelines that have the 140 threshold for office measurement. They do actually say it should be 135 for the out of office measurement, so for ambulatory or home blood pressure measurement. So there is recognition in the other guidelines that you need to adjust this. But in the American guideline, it just says the 130 millimeter mercury threshold for no matter what type of measurement you do.
Yes, one of the problems that they are extrapolating evidence. They are extrapolating from results that were obtained in a very different setup to the real world. But in the real world, it's quite different.
That's true. But I think perhaps the bigger issue with extrapolating from sprint is that they were very high risk people in that trial, and so
also.
So if you're expecting any benefit, you probably would for very high risk people. But then to try and extrapolate that to the whole adult population in any country where most people are very low risk and in fact less than 5% risk,
of course,
seems to be a mistake. But,
of course, yes.
So I think we're up to slide 14.
Yes, that's correct.
Okay, so now we're up to the checklist item number 7. What is the incremental harm for patients classified by the new definition compared with the previous definition? So we thought that there were at least 3 harms for the newly diagnosed people. The first is the labeling that we've already touched on. So there's evidence that labeling a person as having hypertension increases their risk of developing anxiety or depression, increases absenteeism from work. So that was quite a large study out of McMaster University in Canada from starting back in the late 1970s that showed that. And there's experimental work that telling someone they have hypertension may even actually cause their blood pressure to increase. So it could be that the labeling causes the condition. Second, in countries without universal health coverage, and so the US, people newly diagnosed as having hypertension may face difficulties in gaining insurance coverage for what the insurance company can term a pre-existing condition. Third, people with high blood pressure newly treated with medications or treated more intensively are at risk of physical harms related to the treatment. So in the HOPE-3 trial, for every 125 people treated with blood pressure lowering drugs over 5.6 years, 1 person experienced a serious adverse drug effect, such as symptomatic hypotension. And I won't tell you the answer for the SPRINT trial because I think that's the next polling question.
Yes, and I have already shared and we already have answers.
Right.
We were asking our colleagues in the SPRINT trial the number needed to arm with a serious adverse drug effect such as hypotension, syncope, electrolyte abnormalities, acute kidney injury, or acute renal failure was 32, 19, or 50. And most of our colleagues, 43%, answered 32. Then 29% answered 19, but the correct answer was 50, wasn't it?
That's right. So, so on the previous slide, I'd given you the absolute rate of an adverse drug effect, and then you just needed to so convert that to a fraction and then flip it over to get what the number needed to harm.
Okay, yes. In the sprint trial, for every 50 people treated intensively over 3.3 years, one person experienced a serious adverse drug effect from those that I have mentioned: hypertension, syncope, acute kidney injury, acute renal failure. Quite high, a number needed to have.
Yes. Yep. So this was with quite intensive treatment. So as I'd mentioned before, it was something like 12 millimeters of mercury lowering. I can't find it, but yeah, so it's quite an intensive treatment, but reasonably high rate of adverse drug effects. All right, so slide number 16.
Yes.
We have it?
Yes, already, yes.
Yep, okay. So the last checklist item is: what is the net benefit and harm for patients classified by the new definition compared with the previous definition? So this is asking you to, at a population level, weigh up the net benefit versus harms. So this diagram, which is adapted from a BMJ paper that Paul Glasziou and Les Zerweg wrote quite a while back, but still very relevant now, depicts the fact that in absolute terms, the benefit from being labelled with hypertension and potentially being treated increases as your baseline risk increases. So you can see the benefits line increasing as you move to the right. In contrast, that the harms from being diagnosed with hypertension may be more or less this constant, I guess, and that a person, even if they're at low risk of cardiovascular disease, can still be harmed by being given the label. And the same as a person who is actually at high risk will still suffer some harms from the label and from potential adverse drug reactions. So for most adults who have been newly classified as having hypertension under the ACC-AHA guideline, there's no incremental benefit in cardiovascular risk reduction, but potential incremental harms from disease labelling, and for those who meet the threshold for drug treatment, from adverse drug effects. And these people are represented on the left-hand section of this graph in what we call the overdiagnosis zone. For people who are at high risk of a cardiovascular event or have had an actual personal history of cardiovascular disease, the incremental benefits may often outweigh the incremental harms, leading to net benefit. So these people are represented in the right-hand section of the graph, where the diagnosis has clinical utility. The remainder of the people are represented by the middle zone of the graph, where the balance of benefits and harms is uncertain. And if we can move on to slide number 17.
Okay, it's done.
Yes. So I want to now come back to the fifth item on the checklist in more detail. And this is if you remember, what is the repeatability, reproducibility, and accuracy of the new disease definition? Because there's been quite a few commentators commending the new guideline for the fact that the recommendations are addressing some of the problems to do with blood pressure variability, and that's an advantage of this guideline. So let's turn to slide 18.
Yes, it's done.
So when considering the impact of this random variation, or what we call within-person measurement variation, we need to recognize that hypertension, and in fact most diagnoses that we give patients, are what are termed absorbing states in terms of, so it's a health economics term that you have in Markov models. There's something called an absorbing state. And this reflects that once you're diagnosed with hypertension, you can't really get rid of the label. So you don't usually become undiagnosed later on if your blood pressure readings become lower. You're said to then have controlled hypertension, but you don't normally lose the hypertension label. So we undertook a simulation study to estimate the cumulative probability of a hypertension diagnosis if you're doing repeated blood pressure measurements over like a number of years on an individual, and tried to look at what your chance of eventually being diagnosed with hypertension was. So if we move to slide 19.
Yes, it's done.
Yes.
Yes.
So the new American guidelines provide quite detailed instructions on how blood pressure may be measured, including both office and out-of-office measurement. And both the new European and NICE guidelines also try to emphasize taking multiple measurements and averaging them, which is a good thing. So the American guidelines say that you should average multiple measurements both at each sitting and then over repeat clinic visits over weeks. And that there's also a particular emphasis on averaging out-of-office blood pressure measurements like ambulatory or home blood pressure measurements, which again is a good thing. And that this should help with the replication issue and decrease some of this random variation. However, since, as I mentioned earlier in the talk, a large proportion of all adults in the population have a true systolic blood pressure that's quite near to the new diagnostic threshold of 130 millimeters of mercury. So even though there's been these measures to try and improve the reproducibility of blood pressure measurement by averaging more measurements and taking out-of-office measurements, because at the same time they've lowered the diagnostic threshold, the potential for overdiagnosis of hypertension may be increased. So if we move to slide 20.
Okay, it's done.
So we use some empirical data on within-person variation in blood pressure from a study by Warren and colleagues of 163 adults living in Germany. And participants in this study were adults who were perceived to be at a greater cardiovascular risk because of reported previous diagnosis of hypertension, elevated body mass index, or some other factor. And they represented a mixture of the general public and primary care patients. And in this study, the authors sought to determine the average variability of using these different types of blood pressure measurement, and they calculated coefficients of variation, which is just a measure like standard deviation for how much variability is occurring within an individual if you do repeated blood pressure measurements. And so they came up with estimates of coefficient of variation for office blood pressure, which was measured in duplicate and then repeated after 6 weeks, daytime average from 24-hour ambulatory monitoring, which again repeated after 6 weeks, and self-monitoring at home of blood pressure for 7 days with replicate measurements taken twice a day, and then discard the first day's data. And again, that was repeated after 6 weeks. So these the measurements they did are in line with what all the new guidelines say you should do, ideally. And so from that, they were able to come up with what the random within-person variation is for these three types of measurement. And we used their estimates to then say, well, what's the chance of ending up with a diagnosis of hypertension? So if we move to slide number 21.
Yes.
So we constructed a simulated population, which represents the adult US population. And this is the distribution here. So as you can see, a large proportion of the population have a true systolic blood pressure near to the 130 millimeter mercury threshold. And we applied something called the binomial theorem to the reproducibility estimates that I've just shown you from the German study to estimate the probability of being diagnosed with hypertension each time that a set of blood pressure measurements were made in accordance with what the new guidelines recommend for how blood pressure should be measured. So if we move to slide 22.
Yes, it's done.
So here are our findings for people who truly have a systolic blood pressure that is less than 120 millimeters of mercury. So this represents over half of the US adult population and would be over half of any adult population in the world. So although the risk of being overdiagnosed with hypertension was only 3% with the 130 millimeter mercury threshold after one set of office measurements, the cumulative probability increased to 14% after 5 sets of measurements. So, for example, this might represent 5 annual checkups, where at each annual checkup you have a set of measurements where you get the
Katie,
person to come back twice.
let me see let me see if I'm understanding well. What you are telling us is that if we measure blood pressure more often, our chance of getting a diagnosis of high blood pressure is greater.
Yep, that's right, exactly right.
Okay.
So I agree with the guideline recommendations that you should take lots of measurements and then average them to try and get an estimate of the true blood pressure. However, so that's for sort of one measurement occasion. But what usually happens in clinical practice is that we don't sort of only do that once for the patient in their life, that we just keep on doing more and more measurements each time they come, and each set of measurements is kind of considered as on its own without necessarily, like they're not sort of added to the one from last year or the year before to average them. It's usually considered as, this is the new blood pressure measurement. And so if you keep on doing that enough times, eventually you'll be able to diagnose a lot of people with hypertension, regardless of what their true blood pressure is, just because blood pressure has this inherent variability.
Okay. And we now...
so we found that eventually the risk went up to 14% with the 130 millimeter mercury threshold, and that the risk was much lower with non-office measurements, or if the diagnostic threshold was 140 millimeters of mercury, which is the European and NICE guidelines recommendation.
Mm-hmm.
So if we move to slide 23, which is a polling question.
Yes, we want our colleagues to tell us their guess. For someone with true systolic blood pressure between 120 and 130 millimeters, the probability of hypertension overdiagnosis is 25%, 82%, 47%, and this when using a 130 millimeters threshold. And we already have the answers, Katie. 52% of our colleagues answered 47% of overdiagnosis. 33% answered 82% of overdiagnosis. and 15% answered 25% of overdiagnosis. What is the correct answer?
So, our colleagues may be surprised to learn that eventually, so after 5 sets of measurements, it actually reaches 82% risk of overdiagnosis for people in this blood pressure category.
Okay, we are
So
now
if we move
already moving to the slide 24.
You're on slide 10, great. So people who truly have a systolic blood pressure of 120 to 130 millimeters of mercury, who represent just under 1/3 of an adult population. So large numbers of people. And we found that the risk of being overdiagnosed of hypertension after just one set of office measurements was already 31% using the new 130 millimeter mercury threshold. And that the cumulative probability increased to 82% after 5 sets of measurements.
This is amazing.
Even if, what's that?
This is amazing.
Yeah. Well, but it's because, it's so close to like the new threshold, and like the effects of lowering that threshold, that's moving it towards the population mean, is just means that huge numbers of people will randomly appear to be over the threshold. So even if the non-office measurements are used, the risk of overdiagnosis is still very high under the American guideline threshold. And the risk of overdiagnosis with the 140 millimeter mercury threshold is lower, but even there, it still reached 34% after 5 sets of measurements. Okay, so if we move to slide 25.
Yes.
So we need to consider underdiagnosis as well. So in contrast, for the 10% of the adult population who truly have a systolic blood pressure greater than 140 millimeters of mercury, the risk of underdiagnosis or not detecting this was 7% using the 130 millimeter mercury and 12% using the 140 millimeter mercury threshold. However, there's minimal risk of underdiagnosis if even one set of office measurements is repeated, or if non-office measurements are used. So underdiagnosis really doesn't seem to be a big problem. Slide 26.
Yes.
So in summary, our simulations found that there's a substantial risk of overdiagnosis with repeated chances to be diagnosed with hypertension. And this is especially the case for the 130 millimeter mercury threshold, and true even if non-office measurements are used with that threshold. In contrast, there seems to be minimal risk of underdiagnosis of high blood pressure. And slide 27.
Yes.
So this is getting back to some of the issues we were discussing right back at the start about the harms of dichotomizing a continuous risk factor. So one way to prevent overdiagnosis of hypertension might be to stop applying a diagnostic threshold to a risk factor. Instead of focusing just on the individual's blood pressure and whether or not they have hypertension, the measurement could be, it can be combined with other risk factors to calculate the absolute risk of a cardiovascular event within 5 to 10 years. By moving away from using the hypertension label, we may prevent the overdiagnosis of a disease in people who are otherwise at low risk of a cardiovascular event. So not only is the absolute risk approach less likely to result in overdiagnosis from measurement variability in blood pressure, importantly, it also allows the patient and doctor to better assess the size of any potential benefits and harms of starting treatment, and allows for more informed shared decision-making. So the decision to start preventative treatment is sensitive to an individual's values and preferences. Some people are actually willing to accept a small increased risk of a cardiovascular event if it means that they get to avoid taking medications, and then others are not willing to accept that. So if we move to slide 28.
Okay.
So this is an example of a web-based decision support tool that this one is run by James McCormick at UBC in Canada. And you can use these decision support tools to present individualized risk estimates for the patient and present what they would be with and without taking the medication. And in this way, the patient and clinician may reach a decision while also taking into account what the patient's values and preferences are. However, to also prevent over-treatment of low-risk people that may result from some variability in these risk scores, we still, I think, need to have some minimum treatment thresholds. And these should be set at a level where treatment has a net benefit for the population. And there is actually a trend for lowering risk treatment thresholds in the guidelines, but that's a topic for another day. So there has been some comment on the new NICE guidelines, for example, about whether they lowered their treatment thresholds too far. So next slide is 29.
Yes.
So in conclusion, we suggest that that doctors should avoid labeling low-risk people with hypertension just because their systolic blood pressure happens to be above 130 millimeters mercury or even above 140 millimeters of mercury, and that instead physicians should continue to support healthy choices with regard to diet and physical activity and other lifestyle choices. And this should be done regardless of whether a patient's systolic blood pressure happens to sit above or below a certain threshold. For a small number of people at higher risk of cardiovascular disease, the use of medications to achieve tighter blood pressure control is likely to offer net benefit on average. But we don't need to have the hypertension label to achieve these benefits. People who have predicted cardiovascular risk somewhere in the middle, the net benefit versus harm of treatment is uncertain. And as I mentioned before, some people are willing to accept a small increase in risk if it means they don't have to take pills every day or take increased doses or more medications, while other people are not willing to accept that. So in that situation, informed and shared decision-making, considering both their baseline risk and also their values and preferences about the trade-offs between potential benefits and harms are needed. And slide 30.
Yes.
So this is a plug for a conference that the research group I'm part of, Wiser Healthcare, is sponsoring this year. And I know Carlos and Mina are coming. And hopefully some other people on this webinar can come too. So this is the Preventing Overdiagnosis Conference that will be held at the University of Sydney 5th to 7th of December. And although the early bird registration is closed, the registration is still open. So that's a plug for that conference.
Okay.
And then
thank you for the
slide
invitation.
31.
Yes,
What's that?
31. Thank you for the invitation.
And then another invitation for another conference in Australia. So this is the World Congress of Epidemiology in 2020, which will be held in Melbourne in September next year, and some great speakers coming for that. So we'd love to see any of you out in Australia for either one or both of those conferences.
Okay.
And thank you. That's all my talk.
Thank you very much, Katie, for everything that you shared with us. It was really, really interesting. I have only a small comment. I agree that orienting our decisions based in the risk calculation in a more global perspective probably is one of the solutions and is a good way to follow. However, I also have to recognize that it still is not a perfect solution, because, for example, for a very great number of countries, there are no calibrated for calculators for their own populations.
Yeah.
There are so many countries that use, for example, the Framingham calculator, cardiovascular risk calculator.
Yeah, well, Australia still uses the Framingham one, actually. But
Okay, okay. And this also raised some problems. And we also have some evidence that some of the calculators tend to overestimate the risk. So we still all have some problems in this kind of solution that we want to go on with it, but we need more data to turn these calculators in a more perfect tool to use.
That's right. Yeah, no, that's an important point. And so I think like there are ways to calibrate equations like the Framingham equation to using local data so that not every country necessarily needs to do a big cohort study and develop their own equation. Like you can recalibrate using existing equations, but you're right that a lot of countries are, including my own. Well, so I'm actually from New Zealand, and New Zealand does have their own risk calculator there, but Australia is still using the Framingham one at the moment, and that isn't ideal, but it still seems like it probably is a better approach rather than just focusing on blood pressure.
Okay, Katie, thank you very much. We move on to Mina's presentation now.
Thank you.
Are you going to stay with us during Mina's presentation, or are you going to leave us?
I'll try to stay.
Okay.
If my children come in halfway, I might need to turn the video off. But
okay, and I understand
it's starting
that.
to become a bit later in the morning, so the rest of the family is up. But
okay,
I'd love to hear Mina's presentation.
Okay, and you may also comment on it and interrupt us, okay?
Oh, sure.
Okay, Mina, now you are on.
Perfect. Thank you very much. Thank you very much, Katie, for a very interesting presentation.
My pleasure, Mina.
And many thanks for inviting me to do this talk. It's a true privilege to be here. So we have slide number 32, right?
Yes.
Yes.
Yes. I have named my talk today the streetlight effect. And the streetlight effect is when we search for our keys where there is light, although we drop them somewhere else. And I will get back later to what I mean by this in relation to screening for abdominal aortic aneurysm. But first, something about me. Slide 33, please. So I live in a small town on the Swedish west coast called Uddevalla. And this is a beautiful picture from Uddevalla to make you want to come there and visit. It's a very small town.
Very beautiful indeed.
Yes, it is. It's just outside, on an island just outside from where I live. Yeah. So I work 50% as a family physician, and the other 50% I work at Cochrane, Sweden as a senior researcher. So slide 34. So now I would like to know where you are from. I leave that to Carlos.
Okay, I have already shared the question, and we already have a very beautiful word cloud, and we have Portugal, Turkey, Macedonia, Sweden, Denmark, Austria, Poland, Italy, bedroom, Ukraine, home with my pets, couch. So it seems they are very comfortable. Italy, Ukraine, Ljubljana, from a great number of countries.
That's amazing. That's amazing. And it shows also the importance and of this initiative. Amazing.
Okay.
Okay, so slide number 36. I have no financial conflicts of interest related to this talk. Slide number 37. So first, some background on AAA screening. So first of all, AAA is short for abdominal aortic aneurysm. I'm sure most of you know that, but just to be clear. And as you probably also know, AAA is usually asymptomatic unless they rupture. Rupture causes a massive bleeding and has a mortality of over 80%. And screening aims to detect the AAA before rupture to enable preventive surgery with a much lower risk of mortality and complications. So slide number 38. Screening for AAA in 65-year-old men has been implemented in Sweden, the US, and the UK during the 2000s, and is performed with a one-off ultrasound examination of the abdomen. And men with an aortic diameter above 54 millimeters are considered for preventive surgery, while men with aortic diameter between 30 and 54 millimeters are kept under regular ultrasound surveillance for the rest of their lives.
Okay, and the recommendation is for women and men?
Yeah, so women, there are no screening programs for women, and women have a much lower incidence of AAA and also much lower rates of AAA death. And also, women die of a AAA much later in life, which means that the potential for benefit of screening is much lower because they have a higher competing risk of death from other causes.
Okay, and for what age? Men over what age? 50 years old or other age?
Sorry, you mean screening?
Yes, the recommendation in Sweden.
In Sweden, it's 65-year-old men.
Okay.
In the US, it's men between 65 and 74, I think.
Okay.
Yeah.
Okay.
So it's some difference, but it's above 65 or around 65.
And is it a popular screening in Sweden?
In Sweden, yeah, the uptake is almost 90%.
Whoa!
Wow.
Yeah. So the screening program in Sweden, it's organized so everyone get an invitation to screening. So it's not by the GP. It's not the GP that discusses it with the patient, but everyone gets an invitation on their day of the retirement, 65 years.
Okay.
It's a retirement present.
Do you have AAA screening in Australia, Katie?
No, there's no population organized program, so that there probably is some ad hoc screening that the GP can order. Or
Neither in Portugal. In Portugal, we also don't have this screening.
No.
Okay.
It has been discussed in Denmark, but they decided to not implement it now. So. Okay, so slide number 39. So the decision to implement screening was based on 4 randomized trials performed in the 80s and 90s, which in meta-analysis had shown a relative reduction in AAA mortality of 34%. However, the problem with screening for abdominal aortic aneurysm is that we do not only find AAAs that would eventually rupture, but we also find AAAs that would never have caused any symptoms if left undetected. And this is a well-known phenomenon that is called overdiagnosis, which Katie also discussed. Slide number 40. Thanks. So when I started to get interested in AAA screening, I discovered that there were quite a lot of research on the benefits of AAA screening, but very limited research on the harms. It was like one side of the coin was missing. And most of the research on AAA screening was done by vascular surgeons. And it seemed to me that the family physician perspective was missing. And what I mean by this is that I think that inevitably, most vascular surgeons will approach this topic with a man who died in the emergency room of a ruptured aneurysm in mind, a man whose life could have been possible to save if the aneurysm would just have been detected in time. And that is, of course, a very valid perspective. However, as family physicians, we might see a different side of AAA screening. The next slide, please. This is one of my patients who I've known for many years. It's a woman whose husband had a small AAA detected at screening, and because of that, he didn't dare to have sex anymore. And this had major impact on their life and quality of life. So I believe that both of these perspectives are valid, and needed in order to do the research that will be most relevant to our patients. So slide number 42, please. In this study from 2015, we published the first estimates of overdiagnosis in AAA screening. And slide 43. We used this definition of overdiagnosis. A man is overdiagnosed if he has a screen-detected AAA, which would never have caused any symptoms or death or been detected if he had not participated in screening. It is, of course, not possible to know on an individual level who is overdiagnosed and who is not, but it is possible to know the proportion of overdiagnosed men from trials or from epidemiological data. So slide number 44.
Okay, we have now questions in our televoting. What proportion of men with screen-detected AAA would never have had any symptoms of the AAA if they had not participated in the screening? This means are overdiagnosis. Option 1, 10%. Option 2, 25%. And option 3, 45%. And we are receiving some answers. The bars are still quite moving, but 50% of our colleagues answered to option 3, 45% of overdiagnosis.
Well, we have brilliant colleagues because that's the correct answer according to our study.
Okay.
So slide number 46 then.
Okay. The next slide, please. Yes.
So this is our reanalysis of data from the largest randomized trial of AAA screening. These are the AAAs detected at screening in the screening group. That's the left bar. And on the right bar, it's the AAAs diagnosed in the control group after 13 years. So as you can see, there is an excess incidence in the screening group, constituting 45% of all AAAs detected at screening. So these men would never have had any symptoms of their AAA if it had not been detected at screening. They are overdiagnosed.
I'm sorry, how did you detect the AAA in the control group? I didn't understand it.
No, so it was from the RCT. They had gathered information on who had a surgery or who had died from AAA.
Okay.
Yeah.
Yes.
So there are definitely flaws to this estimate because the data was imperfect. So this is really like a ballpark figure. It's not. We can't trust the exact estimate because the data that we would have needed for that is not available.
Mm-hmm.
So, but based on this, we estimated that per 10,000 men invited to screening, 176 men were overdiagnosed after 13 years. And of these, 37 men were overtreated with preventive AAA surgery due to screening after 13 years, which means that they unnecessarily underwent surgery with the risk of serious complications such as stroke, renal failure, myocardial infarction, amputation, and even death. So, slide number 47.
Okay.
Apart from the more clear-cut physical harms of screening, there might also be psychosocial harms that are perhaps a bit more difficult to measure. This is a quote from a qualitative interview study with men under surveillance for small AAAs. Well, there's no point in talking about it because if something happens, then it happens. There's nothing to be done about it. It's just that, and then he starts crying. If one starts talking about it, then one starts thinking right, and that's no good. Another man in this study said that it was like living with a ticking bomb in his stomach. So this is a qualitative study, and the results are, of course, not generalizable. The quantitative studies on psychosocial consequences of AAA screening are unfortunately very poor. So basically, we don't know how much psychosocial harms AAA screening causes. So slide number 48.
Okay, yes.
So as I said earlier, screening for AAA was implemented based on 4 randomized trials that showed a beneficial effect on AAA mortality. However, these randomized trials were done in the 80s and 90s, and since then, the incidence of AAA has fallen by over 70%, as shown in this study from the UK. This is most probably due to a drop in smoking habits, because smoking is the major risk factor for AAA, and smoking has decreased substantially in most Western populations during the last decades. And when there is such a massive change in epidemiology of the disease screened for, the balance between benefits and harms of screening may change substantially. So therefore, it's very important to reappraise the benefits and harms of today's screening programs for AAA. Slide number 49, please.
Okay.
It's not likely that there will be any results from new randomized trials on AAA screening within a foreseeable time frame, and because of that, we have to turn to observational data. The problem in observational studies is that it will be difficult to separate an effect of screening from the strongly declining background trends. But the Swedish screening program presents a unique possibility, because screening was implemented stepwise, county by county, between 2006 and 2015, and this stepwise introduction makes it possible to compare a cohort of men invited to screening to a contemporaneous cohort of age-matched men not invited to screening. And thereby, it's possible to differentiate between the effect of screening and the effect of the decreasing background trends on AAA mortality. Slide 50.
Yes.
Thank you. And that's what we did in this study, published last year. Slide 51, please.
Okay.
So we found that AAA mortality has decreased by about 70% in Swedish men aged 65 to 74 over the past 2 decades. Reductions started 10 years before screening. They were similar in areas offered and not offered screening, and they occurred in both screened and non-screened age groups. So that's why we concluded that the majority of the reduction was unrelated to screening. As I said before, it's very likely due to a drop in smoking habits.
Interesting.
Slide number 52, please.
Okay.
Thank you. So these are cumulative rates. On the left side, it's the cumulative rates of AAA death in a cohort of men invited to screening compared to a cohort of men not invited to screening. So the red is the screened men and the blue is the non-screened men. And the y-axis is percentage points and the x-axis is years after screening. So as you can see on the AAA mortality graph, there is a difference in AAA death between the screening and the control cohort, but the difference is not statistically significant, and it is much, much smaller than that seen in the randomized trials. On the right side, it's the cumulative rates of elective AAA surgery in the screening and control cohort. And as you can see, there is an excess rate of elective surgery in the screening cohort compared to the control cohort. This is to be expected, since the whole point of screening is to avoid AAA rupture through preventive surgery. So you want to change the rupture to preventive surgery. So you expect a higher rate of preventive surgery in the screen group. However, if we look at the two curves together, if we look at the curve for AAA mortality, we see that the increase in elective AAA surgery in the screening group is not compensated for by a similar decrease in AAA death in the screening group compared to the control group. So in other words, very few of those who undergo surgery due to screening seem to gain from that surgery in terms of avoiding AAA death. Yeah?
Yeah.
Mina, can I ask a quick question?
Yes, please.
Did you have any data on emergency AAA surgery?
Yes. Yeah.
And what did that show?
Very good point, because it's not only the point of doing preventive surgery is not only to avoid AAA death, it's also to avoid acute surgery that you would survive, because complications are much higher for acute surgery than it is for preventive surgery. So most people would prefer to have preventive surgery instead of acute surgery that they survive. So that's a very good point. So when we estimated, we had a compound measure. We had no direct measures of rupture, but we could combine AAA deaths and acute surgery that they survived. So we combined it in a compound measure, and that's and when we estimated overtreatment, we took the excess of elective surgery and took away those who had died,
Sure.
or the decrease in death or acute surgery. So we assumed that would be rupture then, but very good point.
Yeah.
So there was also some difference in rupture, or what we call then rupture, but it was also much smaller than in the trials. Okay, slide number 53.
Okay.
So we estimated.
Here
Sorry?
we have the balance between benefits and harms.
Yes, exactly. Some of the benefits and some of the harms, not all of them. Yeah. So we estimated that for every 10,000 men invited to screening, 2 men avoided AAA death after 6 years. But this effect was not statistically significant. And at the same time, 49 men were overdiagnosed, of whom 19 men were overtreated with elective AAA surgery, which is a surgery with considerable risk of serious complications and even death. So slide number 54, please.
Okay.
There are, of course, limitations to our study. These include the non-randomized design. Although we control for confounders on an individual level, residual confounding cannot be excluded. However, in our control group, which was the counties that had introduced screening later than our screening group, it was actually a higher baseline rate of AAA death. So it's likely that residual confounding would exaggerate the benefits of AAA screening. We don't know that, but that's the baseline imbalance was in that direction. Further, since follow-up was limited to 6 years, the full effect of screening might not have been captured. So some of the men that we said were overdiagnosed might have had a benefit later on. But however, in the trials, the majority of the benefit in absolute terms was obtained within 7 years. And the effect on AAA death seen in our study constituted a 93% drop compared to the effect seen after approximately the same follow-up in the largest randomized trial.
Wow.
Okay. Yeah, it's quite large. So slide number 55, please.
Yes.
So we concluded that the effect of screening on AAA mortality is at best small, that the benefit-harm balance is substantially worsened compared to the randomized trials on which the implementation of AAA screening is based. And we argued that the continued justification for AAA screening should be reevaluated. So slide number 56, please.
Okay.
So whether the benefits of AAA screening outweigh the harms or not, that's, of course, a value-based decision. And I really want to stress that, in my view, it's not up to individual researchers to decide whether screening is worthwhile or not. The decision on whether to recommend or invite people to screening should be made by an independent committee with a broad representation of people from within and outside of medicine, all of which should be free from financial and intellectual ties to the screening intervention. That's my view. Unfortunately, when the Social Board of Health and Welfare in Sweden investigated AAA screening a few years ago, as experts doing the investigation, they chose 3 vascular surgeons who had all been responsible for the implementation of AAA screening in their counties. So not very surprisingly, they decided to recommend AAA screening. And in my opinion, they did not adequately consider the consequences of the 70% drop in AAA mortality and the consequences of that drop on the balance between benefits and harms. Actually, they hardly considered harms of AAA screening at all. So my next question for you.
That is quite concerning. Can you share a little bit of the impact that you felt in your country when your study was published and your conclusions were public?
Yeah, I could. It was, I think, as a family physician doing research on this topic, I have gotten a lot of response from vascular surgeons that it's not my topic. You know, I can't say anything about this because I've never had my hands in a bleeding abdomen. And I think there are some arguments. I can understand that perspective, that it's that as a vascular surgeon, seeing this man die on the surgery table. I mean, I understand that perspective adds something. But I think that we as family physicians, we see this from another perspective, and that perspective is also very valid. So I'm not saying that it's. I think both sides needs to come in the situation. But what I have experienced is actually has not been very pleasant. I've had many anonymous hate mails with extreme, terrifying sexist content, and they have called my future boss to try to get me fired and stuff like that. So it's been quite harsh.
That is really sad.
Yeah, but I have many colleagues around the world that has been great support. So
yes, you also have our solidarity, because it's so sad to hear such things and to think that someone makes this kind of bullying just because we share with the world the data we have and the results that we have found. It's unthinkable, really. It's really sad.
Thank you very much for that comment. I think I want to add to that I think it's very important that we have a high level for criticizing each other's research. So I welcome every critique to my research. I think it's very good to have a very open debate about that. So it's not, I have nothing against that, but the personal.
It seems like they couldn't criticize your research, so instead they were just doing personal attacks, which is awful.
Yeah. There are. I think you could critique my research, but it could be done in So thank you very much for your support. So.
Mina, we have here a question from Katarina.
Yeah?
She's asking, could we extrapolate these results to other populations where smoking is more prevalent?
Yeah, that's a very good question. So I think the reason that we found a lot less benefit from AAA screening in our study than RCTs is very likely due to the drop in smoking habits. So in countries where they have the same smoking habits that they had when the RCTs were done in the 80s and 90s, that the benefit is probably much larger than we found in our study. However, it's also some other aspects. For example, and nowadays we do much more X-rays of the abdomen anyway, so we find many of these aneurysms opportunistically, which means that the benefit from screening is less. Also, in the RCTs, there were no estimates of overdiagnosis, and I would say no real estimates of overtreatment. So when considering, even if you wouldn't consider the 70% drop in AAA death, it's still a matter of a balance between benefits and harms. So even in populations where you have more benefit, there will also be quite a lot of harm from AAA screening. And I think it's important when because in AAA screening, it's really, you can overdiagnose, through screening, you can overdiagnose a man who undergoes surgery, and in that surgery, he can die. It's actually not a huge, but a substantial risk of death in that surgery. And that's ethically complex. So I think
I was just thinking about that we have to take some care with this kind of extrapolations for different countries, because we have to be aware that to get the entire benefit of this kind of screening, we have to have available in each country also high quality vascular surgery and so on. Because this is a delicate surgery, it requires high skill, good equipments, and good healthcare access for the populations. And
and there's also a very good point. And there's also the opportunity cost within the healthcare system. It's a big surgery. So if you have limited resources on that, it takes surgeons, it takes anesthesiologists, it takes inpatient care, and many of these patients end up in intensive care units for a while after surgery because it's such a big surgery. If you do the open surgery and not the endovascular, then so there are many aspects of this.
It also is the kind of surgery where we have quite different death rates among different hospitals, for example.
Yes. For example, in Sweden, the mortality after surgery is much lower than in many other countries. So there are many, and I would say that, I mean, you would have to make a very careful analysis of the balance between benefits and harms. Unfortunately, that's very rarely done. It's too little of that. We tend to look at the benefits and then decide based on the benefits, but we should look at the harms for the individual and the harms for the healthcare system in terms of human and financial resources. So we need to combine those and then see, is it worth it or not, before we decide to recommend it. That's my view. Okay.
So we already have the answer to the question, how many family physicians were involved in the Swedish board. 73% said 0.
Yes.
Is it correct?
It is correct. There were no family physicians involved. And I think this is outrageous, because our perspective is obviously needed to get a balanced understanding of benefits and harms of screening. So the next slide, please.
Yes.
59.
Yes.
So my most important message in this talk is that the world needs more influence from family physicians in guidelines.
We can do it.
Yes, we can do it.
Yes, we can.
Okay. So that was an open goal in this audience, I think. Okay, so slide number 60.
Yes.
So this is, I will end my talk with a quote from David Sackett, often called the father of BBM. So he wrote, the two disciplines, curative and preventive medicine, are absolutely and fundamentally different in their obligations and implied promises to the individuals whose life they modify. When patients sought me out to help with their established symptomatic diseases, I promised them only to do my best. But surely, the fundamental promise we make when we actively solicit individuals and exhort them to accept preventive interventions must be that, on average, they will be the better for it. Accordingly, the presumption that justify the aggressive assertiveness with which we go after the unsuspecting healthy must be based on the highest level of randomized evidence that our preventive maneuver will, in fact, do more good than harm. Okay, so my last slide, number 61.
Okay.
So the title of this talk, The Streetlight Effect, is a metaphor for our propensity to focus on aspects that appear well demarcated and intuitively appealing to seek control over, while ignoring less approachable, but sometimes more meaningful answers that are only to be found in between the biomedical light posts. Thank you for your attention.
Thank you, Mina. Thank you very much. It was really great. And before we say goodbye, I would also like to make an invitation, because EUROPREV is organizing a conference. It will be in next November, 4th and 5th November, here in Porto, Portugal. And I would call our colleagues to come to Porto and to attend this conference. I think we have a really great, interesting scientific program, and it would be great that you could join us here in Porto.
I'd love to come.
It would be great. You come in November to Porto, and I'll go to Sydney in December. So, dear colleagues, thank you from all over the world. We have just received a message from Giselle from Philippines. Thank you very much for attending this webinar. And Katie, Mina, thank you very much for your participation and for everything you have shared with us. I would give you now both the word for a goodbye.
Thank you very much for inviting me to be part of this, Carlos. I really enjoyed it.
Are your children still asleep?
No, I can hear them out.
Okay, where is Mama? Where is Mama? We want breakfast. Okay, bye-bye and thank you.
Okay.
Thank you very much.
Thank you very much.
Mina?
Bye-bye.
Yes, thank you very much. It was a true pleasure to be here. Fantastic. Thank you very much.
Okay, thank you. Rosalia, thank you so much for helping me passing the slides. I hope you enjoyed it.
Yeah, it was a great webinar. You both made excellent presentations. Thank you.
Okay.
Bye-bye.
And I would like to remember our colleagues, for those who are interested in receiving a certificate from the all-year webinars, I have already shared in the chat a link where you can make your attendance check. Please, if you are interested in the certificate, don't forget to do it. Bye-bye. Until next webinar. When will it be?
November.
Next 22nd October.
October.
And it will be about asthma. It will be also a very interesting webinar. Bye-bye. Have a nice evening for those of you who are in Europe. For those of you who are in Australia and other countries, have a nice day. Bye-bye. See you soon.
Bye-bye.
Bye-bye. Thank you.